Thank you, everyone, for joining us here today. Let me know if you can hear us pretty reasonably well. I know it's early on a Saturday, so I really appreciate you guys joining. This is a yearly event. It's a PRS Journal Club live event. We typically hold these on Facebook, as most of you know, but here we're fortunate to be in person with one of the co-authors for the paper that we're discussing today. And I'm here, as always, with my other PRS ambassadors, Emily Long from BIDMC Harvard and Ronnie Shammas from Duke University. We have the honor of being joined today by Dr. Summer Hanson. Dr. Summer Hanson's at the University of Chicago. In addition to having a very busy clinical practice with all aspects of reconstructive surgery, she directs all the research efforts at the University of Chicago. She completed her residency training at University of Wisconsin, followed by her microsurgery fellowship at MD Anderson Cancer Center. So the article that we'll be discussing today is really different techniques, a prospective evaluation of different techniques in autologous fat grafting. And the way the structure is, we're going to review the article, and Dr. Ronnie Shammas will do that, and then we'll have a discussion, a Q&A session, where you guys are all welcome to ask whatever questions you want. And again, Dr. Summer Hanson will be here to answer those.
Yeah, so we'll start off with a brief overview of the article itself. So autologous fat grafting is a useful tool in cosmetic and reconstructive surgery with a wide range of applications that extend beyond using it as a filler simply for volume replacement. When processing the fat, there are several techniques described, and these include centrifugation, washing, in addition to filtration. So the authors of this study previously conducted a prospective randomized controlled trial which looked at the operative outcomes of these three common processing techniques. And they found that there was a significant difference in the rate of processing for the tissue with active filtration, so a system like the Revolve system demonstrating the fastest rate of processing. So the purpose of this study was now to compare the short-term and one-year clinical outcomes of these three commonly used systems for processing the fat. In addition, and this involved Revolve, which was the active filtration device, ProGraft, which was passive filtration, and then the centrifugation for the processing of fat. And the authors hypothesized that centrifugation would demonstrate the highest rates of fat necrosis with additional grafting needed when compared to washing and filtration techniques. So to conduct this study, this was a randomized prospective study which compared the outcomes and processing techniques for fat grafting. The authors collected basic demographic, medical, and surgical history in addition to information regarding complications within a 30-day period. Longer-term outcomes related to fat necrosis and contour irregularities were also recorded. When we looked at the results of this study, so a total of 46 patients were included, 15 were randomized to active filtration, 15 were randomized to passive filtration, and 16 were randomized to the centrifugation arm of the cohort. All patients were women who underwent fat grafting for breast reconstruction. The average volume of fat injected per breast was 90 milliliters, or 90 cc's, and the overall complication rate was 12.1%, with all complications being recorded as fat necrosis, and a similar incidence represented across the three cohorts. More than a third of patients had persistent contour irregularities at the breast level, with no significant differences between the three groups. On univariate analysis, the authors showed that fat necrosis in patients who had breast conservation therapy, patients who had breast conservation therapy in general had a higher incidence of experiencing fat necrosis as compared to when comparing the three processing techniques. And overall, the results of this study suggested that when comparing the three different techniques for the processing of fat for grafting, there was no statistically significant difference in the rates of fat necrosis, contour deformity, or the need for additional grafting when specifically looking at the technique for processing alone. So overall, I thought that this was an interesting study which provided a randomized prospective analysis of the outcomes of fat grafting after using these three common techniques for processing. And I welcome any further discussion from the audience about their experience using these three techniques. And I first want to open this up to Dr. Hanson to discuss her general thoughts and takeaways from the results of this study.
Thank you, and thank you for the invitation. I really much enjoy the PRS Journal Club Live on Facebook, and so to be here in person and to be able to discuss our paper, I think is really a privilege, and I appreciate the invitation. I also welcome any discussion that you guys have about your experience with fat grafting techniques, any questions that you have about the paper. I'm happy to answer that. I think that there are a couple of takeaways from this paper that I think has somewhat impacted my practice. I think that the finding that there was no difference in fat necrosis, contour irregularity, fat grafting, additional fat grafting among any of the techniques kind of points to how you then inject the graft or how you deliver the tissue rather than what you're doing to it in the short term, assuming that you're not doing anything beyond minimal manipulation or minimal processing. Once you start getting into different supplements and cells and things like that, that's a whole other story. But I think for this, we really thought that centrifugation would have more fat necrosis or more rates of reabsorption because it's a little bit less predictable in terms of the quality of the graft that you're getting with the number of cells and the amount of sort of contamination in terms of erythrocytes and free lipid and things like that. But it turns out it wasn't. Once we processed that graft, there wasn't a difference in fat necrosis. So that's kind of pointing us to how we prepare the tissue or the recipient site and how we actually deliver that graft as more important. And then the other part of it is that the area where we did see a significant difference was patients who had breast conservation. So those were all radiated breasts that were getting fat delivered, and they were all had some sort of scar as well. And so it just kind of, again, speaks to the recipient site as a potential factor in terms of your outcomes.
Thank you, Dr. Hanson. I was wondering if you could talk more about how you quantified the fat necrosis in the patients in the study. Were they undergoing imaging, or is it based on physical exam?
Yep. So with the way that the study was set up, there was no there was no set imaging that we were doing. But if a patient had a palpable area of abnormality on exam, then they automatically, because they're part of the study, automatically went to have an ultrasound to look for either cyst or fat necrosis or what it might be. And so with our radiologists, we would look at that as what was causing the abnormality, and in these cases it was all fat necrosis. And then they were treated subsequently with aggressive massage, and oftentimes we would recommend a biopsy because these were all patients that were undergoing oncologic treatment. But to start, it was physical exam, and then that prompted the imaging.
How do you counsel your patients preoperatively about the risk of fat necrosis? And they're undergoing cancer treatment. They're always really nervous about a palpable mass afterwards. What's your preoperative counseling like for these patients?
Yep, so we talk about that with everyone, that there is a possibility that, so we talk about the process of the fat grafting and how it takes, and that depends on new blood vessel ingrowth, and if it's not getting good blood supply, it may form a cyst or an area of necrosis, and what they'll feel is a mass. So in those patients, because they've already had a cancer history, we talk a lot about this and what that might mean. And we say that, it's definitely something that if you feel an abnormality, we want to know about it. The majority of the time, it's fat necrosis, and it will either go away on its own or we can treat it. But it would prompt additional imaging and things like that. And then we just talk about what that looks like versus what we're trying to address. So if it's a large contour deformity or a large area of scar, most of the time they're willing to accept that potential in order to address the contour irregularity or the scar. I have had patients that say, you know what, it's not worth it, and then they, we delay.
Since you didn't really find a difference in the processing techniques, is there any plan to study some of these other variables that might play a role, like the recipient site, but also the delivery method? And then, given your expertise and obviously everything that you've done for this study, how would you advise us to fat graft in the future to give it the best likelihood of not only take, but less contour abnormalities, fat necrosis? What are kind of your recommendations?
So we are looking at some of the other factors or variables that could play a role in terms of the delivery. And I think that if you look back at all the studies that have been done, and including a lot of the systematic reviews and other types of reviews, all of the steps along the way that could affect your results in terms of cell viability and fat take pretty much come out in the wash, so to speak, when you do any type of processing. And so, we looked at the more common devices that were available at the time between PureGraft and Revolve. But, since then, this is an area where I think industry has expanded faster than the research. And so you could look at any of the other 10 devices that are out there and try to see. And my guess is you'll probably have a similar result if they have some sort of washing step and some sort of filtration step. Because I think the differences in the filter size is not going to be so much that all of a sudden you're going to have something where you get, 4 times as many cells or something like that. So I think that would probably be the same. I don't know if it's worth repeating this study on every single type of device that's out there. So I think what we've been focusing more on then is like the delivery technique. And so one thing that we know from some of the very elegant studies that Peter Rubin has done at Pitt and some of the studies that we've done in our own lab is once you get to a large size bolus or a large size of fat that's being grafted, 3-dimensionally, that you will get central fat necrosis. If you think of how a skin graft takes, a fat graft is very similar. And the skin grafts that we put down are very, very thin and pretty, widespread or 3-dimensionally. There's one aspect that's much thinner than the rest. So when you put in a fat graft, if you're putting in a big bolus or, a large area that has to get that new vessel ingrowth to the center part of that graft, chances are it won't. It'll become necrotic before it actually takes. And so what we try to do is maximize the amount of surface area of the graft that's in contact with the recipient bed. And so that means just multiple passes, multiple planes, but very small volumes being delivered as you inject. And then the other part of it is not stressing the graft as it's going in. So we use relatively small syringes, like up to about 5 cc syringes, sometimes 3 or 1 even. And then I usually use like a blunt tip cannula just because a lot of what I'm doing is grafting around implants as well. And so I don't want to get through that capsule and hit the implant. So I use a blunt tip cannula. And then we inject as we withdraw the syringe so that you're not putting in graft and putting in graft as you're going in and out and trying to, again, avoid those boluses. The other thing that we found in radiated tissue, especially if you're going to an area where there's a lot of scar, is trying to break up that scar is helpful, or trying to mask around it. And so not directly injecting into that scar because there's just not going to be any blood supply there, but kind of putting layers around where that scar is, or cutting out the scar altogether and then trying to graft into that space.
I guess I have a follow-up question. What kind of volumes, are you using, maximal volumes of fat grafting? You mentioned 1 to 3 cc's injections, but what would be the max that you would use? And then when you're doing it around an implant, what part of the case do you do it? Do you do it at the beginning without the implant in, or at the end once the implant's in, and just be extra careful to not hit the implant on the back of the way?
So I will clarify the 1 to 3 cc's that I was talking about were the syringe sizes that we used. So that, if you have a 10 cc syringe, you can really push a lot of force through that into that small cannula, and you can get a lot of shear strain or shear stress on the graft as it's going in. So we use the smaller volume syringes just to try to minimize that amount of force that you can put on it. But even then, I'll insert the cannula, and then as I'm withdrawing, it's basically 0.1 cc, 0.2 cc's as you withdraw. And then, so I think, again, in Peter Rubin's study, I think he found that the volume of 1 cc over a 10 centimeter pass is about the maximum that you want to do. Now, I'm not sitting there every time measuring out 10 cc, and doing that, but just I do it enough now that I can get a sense of how much I'm putting in, or if there's any difficulty in expelling the graft because of either some fibrotic tissue or something like that, we'll actually take it out and rinse the cannula first and try to pick out any of the fibrous material so that I'm not all of a sudden pumping in a big bolus or a big volume. So as far as when to do it, so a lot of times I will do this at the second stage when they're having a tissue expander removed and an implant placed. And in those cases, we do often use sizers. So we'll take out the expander, do any capsule work that needs to be done. And if it's a very aggressive capsule work, or there's a potential for the skin flaps in certain areas to be thin, I'll oftentimes delay the fat. And we talk about doing this as a separate surgery then. But if it looks like the tissue is healthy and there's a good recipient bed, I will put the sizer in and then do my fat injections.
take out the sizer, irrigate the pocket again, and then put the implant in. So I don't like to do it when they're flat because I want to know what I'm working around in terms of the implant. And a lot of times the implant shape is different than our tissue expander. So that's where I think the sizer is helpful. You certainly could do it still around the permanent implant, but every now and then when I take that out, there'll be some fat in that pocket. And so we irrigate and flush that out before it grows.